Thanks, Eric, and thanks to SAGES for inviting me to talk today. So my topic was internal drainage and septotomy. How do I use that? Oh, I have nothing to disclose. So what the resolution for my debate was that it was internal drainage and septotomy is absolutely the way to go. But some of the caveats for this is that there is a potential for balloon dilation that's needed, typically for late or chronic sleeve leaks and in a stable patient. So with that in mind, what I want to outline today is really the theory behind septotomy, performing a septotomy, safety of the procedure, and conditions for success. So basic assumptions here: sleeve leaks can generally be categorized based on their etiology and defined by their duration. Etiologically, there's mechanical leaks, that just a breakdown of the staple line somewhere along the sleeve. And then there's also ischemic, related to poor blood flow at the proximal sleeve near the angle of His, which in and of itself or with distal pressure will cause a leak, typically proximally. Duration-wise, sleeves are defined as acute, less than 7 days, early 1 to 6 weeks, late 6 to 12, and chronic greater than 12. In terms of the mainstay of management, as Dr. Fung outlined, controlling sepsis and stabilizing the patient is important, defining the leak, managing potential complications, and fixing the leak. So the theory behind septotomy plus or minus dilation is that you address this pressure gradient that exists that drives gastric contents from the sleeve into the lumen of into the abscess cavity. So you address it by essentially incising the fistula tract to try to equalize the pressure between the cavity and the sleeve, and then also dilate the distal sleeve to decrease the pressure in the sleeve itself. How do I point? Oh, there we go. Okay. Right there. Okay, perfect. So septotomy plus or minus dilation really can manage the potential collection and fix the leak at the same time. So how do we do it? Goal is to incise the septum until the base of the abscess cavity is visualized through the sleeve. So initially, you have to ensure your patient is nutritionally replete, get imaging studies to understand the anatomy. An upper GI swallow is pretty cool. It works pretty well, not only to understand the anatomy of the leak, but also to understand the anatomy of your sleeve. Where's the twist? Where's the narrowing? Steps, I would perform this in the OR under general anesthesia. I start with initially an EGD to examine the anatomy of the leak and the anatomy of the sleeve. Make sure you do this with CO2 because you're going to be using cautery. So, and by the way, all these images are from this series by Schnell and their group. So you can see here that first step is to clear out the abscess cavity. On this picture here, if I can, on that picture there, that black arrow is the sleeve. The white arrow is the abscess cavity, and the septum you can see with the gray arrow. So clear out that cavity first. Then, using your heat source of choice, you're going to now start incising the septum. The middle picture is pre-incision. The last picture is post-incision. When you incise, you're not going to go through that whole septum on your first go. You're going to inch your way down. Resolve the distal stenosis using some sort of dilation. And here they've used, I think it was an achalasia balloon. Repeat if needed, not only at the index, not only at that session, but bringing the patient back multiple times. And then follow up with an EGD to ensure resolution. So you can see here, this picture here is after 2 sessions. And you can see how the abscess cavity is resolving. The middle picture is after 3 sessions, and the final picture shows the sleeve lumen with the black arrow, and the gray arrow shows what was left of the septum. So risks, obviously. Risk of bleeding if you incise the septum, but the series that are out there have demonstrated that this can be managed endoscopically. Certainly, you can perforate the septum or the sleeve distally if you stretch it too much. In this case, this needs to be managed surgically, and that's why I would do it in the OR. And certainly, if you first start, do it with laparoscopic visualization as well. There's no reason you can't. And then, of course, you can have non-healing fistulas. So this is a collection of studies I found that had more than 1 patient. And just to kind of give you an overview of septotomy, and basically the time from leak to septotomy ranges from about 6 weeks to 53 weeks. There are different types of thermal energy that you can use, triangular knife or APC probe, different types of methods of dilating the sleeve using achalasia balloons or pneumatic balloons. Sessions-wise, meaning the number of times you bring a patient back, is about 2 to 5, and overall success rate is about 80 to 100%, success being defined as obliterating that perigastric cavity and no need for further surgery. And this is, and the beauty of this is it can be done as an outpatient. So in summary, the management of a sleeve leak with a septotomy really depends on the anatomy of the fistula. You really want a perigastric collection. You don't, where there was a large wall between the abscess cavity and the sleeve. Those fistulas that are really long and narrow and end up somewhere out near the spleen, they're probably not as good for a septotomy. Secondly, time for presentation. Later leaks that have more mature cavity, you'll have success with. And degree of stomach stricturing. So you really have to decide how much you're going to stretch a stomach out or how much you're going to try to untwist that stomach before you either perforate it or it twists back and you're just going to have to do something else. And so for the criteria for success with septotomy, as I mentioned, clean out the abscess of debris, incise that septum so that you can see the base of the abscess, dilate the sleeve distally. First time you do it, you admit the patient, do an upper GI swallow the next day. If it's negative, start oral feeding. And then repeat your sessions as needed every 3 to 5 weeks. And my final slide really just shows this algorithm in terms of where this lies in our arsenal of managing it. And really, we're coming down this pathway here of a hemodynamically stable patient with a localized collection, and here, under internal drainage, is where septotomy lies. Thank you.